Is when I started doing hip preservation surgery. To dive into the topic of hip impingement. I mentioned it several times already. The concept of hip impingement came as a complication of overcorrected periasteal osteotomy. Right? Professor Gans was doing his CAOs and said, oh, I got 50, 60 degrees of CE angle, great correction, but they were losing range of motion. And he started opening up the hips and found that there was labral damage, cartilage damage, and found that overcorrection is not good, and developed the concept of hip impingement. And when he started off saying that he called it osseous stop, a bony block, or coxothermal conflict. All these three words were used to discuss this topic. From my understanding of the various types of FAI that I'm going to discuss, the all-inclusive definition of FAILP is a movement-induced problem. It's a motion-induced problem, pain and damage from morphological abnormalities of the femur, acetabulum, or both. It's an all-encompassing thing. Abnormalities of the femur and acetabulum causing stress in the hip with motion, causing impingement. That's what it is, fully inclusive. In comparison, dysplasia is a static overload. You stand and you damage your hip. In impingement, you don't damage your hip while you're standing. It's movement, running, jumping, sitting down, hyperflexion, what causes damage to the hip. So types of FAI. There's a standard intra-articular FAI that most of you are familiar with, cam and sensor. But there is impingement outside the joint also that happens. Extra-articular. The classic is subspine, very common. I see it all the time. Subspine is AIIS hitting on the femoral neck when they flex up. Usually they have pain in full flexion. 100, 110 degrees, 120 degrees of flexion is painful. That's more typical of subspine impingement. Usually coexists with intra-articular impingement. So it's not an exclusive diagnosis usually. It does go along with intra-articular pathology. I'm going to start with some examples there. All of you will appreciate that there is an AIIS fracture on the right side, but the left side is normalated. This patient is predisposed for impingement from the overcoverage, right? That's a very deep acetabulum. The femoral head is 100% covered. Very prominent AIIS. It's a type 2 AIIS. This happens to be above. In my experience, about 95%, maybe I would say 100%, I don't remember any boy who had an avulsion fracture who did not have underlying impingement. I didn't write the paper. I tell my residents about it, but we have never published it. And with girls, it's not as common. They can have avulsion fractures without impingement in girls. But boys, everyone I see, AIIS or ASIS or ischial tuberosity, they all have impingement. It predisposes them to have impingement. So this right side AIIS will heal, a little more prominent, the callus. Even the left side is prominent already, and the right side will be more prominent and is likely to get into trouble. I don't recommend prophylactically doing anything to the AIIS, but be aware that they'll impinge, and if they impinge afterwards, you take care of them. It's a pretty simple operation to do afterwards. Same thing when he heals, you can see how, as he flexes up, that bump can limit flexion, right? That's if somebody is more prominent, avulsion fracture healed with the spurs coming down, the type 3 AIIS, right? This definitely will impinge. Usually, arthroscopically, you can see the soft tissue in the front of the neck impinge. It's not the same as labral damage. It won't cause arthritis. It's just painful. Right? The subspine impingement treatment for that is just resect this off. It's very easy to do it arthroscopically once you're proficient with arthroscopy. This is an extreme example of somebody with AIIS avulsion that just healed like a long bony rod, like that. Here, I chose not to do arthroscopy because it's too much of a resection. This takes a long time. So just simple open approach. So everything I talk about impingement does not have to be done arthroscopically. Just because I show arthroscopic pictures, you don't have to believe that you have to learn arthroscopy. All these can be very well done with standard open operations. A liquid approach will be fine for that resection. There is a greater trochanter in the coxa vera, like a post-Perthes deformity. It's not impinging directly on the ilium, but there's a lot of soft tissue that gets pinched between this trochanter and the ilium. So you have trochanteric impingement. The simplest treatment is to advance the trochanter down, which most of you are very aware of. But do not cut it here, like that slide that Saral showed. Right? If you cut it here, it kills the blood supply to the head. You can cut up there, take it down if you want to, or without it, advance it to character. Ischio-femoral impingement, right? On the right side, you see multiple enchondromatosis, made the lesser trochanter much more prominent. The space between the ischium and the lesser trochanter became narrower. The bones may not touch each other, but the quadratus femoris muscle is there in between the two, gets crushed, as you can see here, the edema in that area. The clinical sign for this thing is patients will into dynamically, there no deformity. They want into so the lesser trochanter is more posterior with the walk, and they walk with the lesser stride length, so they won't bring the lesser trochanter against the ischium. They take short strides with intoing to prevent pain. Right? The treatment is either you resect it endoscopically, just remove the prominence, shave it off, or open, cut it, transfer it distally, and fix it with a screw. Now intraocular FAI. I'm trying to give you all types of FAI. All types of FAI I'm going to discuss. I'm at least mention. Regionally, intraocular FAI that I've seen, I won't say I've seen. I haven't seen posterior FAI in my practice yet. It saw me several times, but I probably didn't see it. So, but the types of FAI that exist are anterior FAI. 90% of my FAI is anterior. Flexion and internal rotation brings the neck against the acetabulum and causes damage. Right? 90% of FAI is anterior FAI. The 90-degree flexion test with internal rotation impingement sign is very appropriate here. Lateral FAI, a big cam bump that extends to the top of the head and goes posteriorly, causes lateral FAI in abduction and external rotation. Right? A frog lateral thing will bring the bump against the posterior superior acetabulum. That's lateral FAI. It's about 10-15% of the anterior FAI in extent. I never seen lateral FAI without anterior FAI. It's an extension of anterior FAI, a bigger cam. Right? Posterior FAI is diagnosed by extension and external rotation, usually coxa valga or very anterotated acetabulum with lateral posterior coverage can cause posterior impingement. Like I said, I don't look for it routinely. They probably came with that problem in my practice, but I probably missed it. And I would diagnose one, I would treated one with posterior impingement. It's uncommon. Now that we discussed the types of FAI, I'm going to try to tell you what types of damage FAI can do. Now we talk only about intraocular FAI right now. Also, I'm focusing on anterior FAI. We excluded every other type of impingement, talking about common form of anterior FAI. Can you hear me without this mic? It's all right? So I don't need to focus on the... All right. So everyone heard of CAM, right? CAM is from asperistial femoral head. That's the only cause. The femoral head is supposed to be round, goes in, has a bump. It's a CAM bump, right? And that is damage, whether by blocking motion or entering the acetabulum in and squeezing against the articular cartilage. And CAM always has to be from the femur, no question. CAM is always from femoral deformity. Pincer, majority of the time is from the acetabulum, but not always. You can have pincer impingement from a bone spur or some prominence of the femoral neck. Right? That's pincer. Counter-coup damage is something I'm going to show examples. It's very rare. Anterior impingement causing posterior subluxatory force on the head, causing damage to the posterior labrum and the acetabulum in the back. Counter-coup damage. And SCEPI, everyone describes it in the books right now. SCEPI is a prototype of CAM impingement. We presented a paper in 2013 and trying to write a paper, presented the paper, I'm going to try to publish it soon, where CAM and SCEPI are totally different. I'll show you some examples. The CAM damage, a little more details of CAM damage. What happens in CAM damage? A spherical femoral head causing chondrolabral separation, so pushes the labrum up and squeezes into the acetabulum to cause cartilage damage. Let's see some examples, right? CAM bump, flex up, internally rotate. Ideally should not be a red labrum. The labrum is pristine and healthy in CAM for a long, long time. It's nice white triangular labrum, small labrum, but what happens is labrum has no bones to keep it in place, so it gets pushed off. And if it gets pushed off a million times, right, which happens within days of regular activities, there's a cleft that develops between the labrum and the acetabulum cartilage. Right? That's all it is. Type 1 labral tear. Tell this class for type 1 labral tear. So it's not fully a labral damage. The labrum got separated from the articular cartilage because the bump pushed it up. This articular cartilage cannot be pushed up, gets squeezed, and it debars from the subchondral bone, You start developing damage there with flap. And the more deeper the cam can enter the hip, when you force yourself to get more range of motion, trying to bend and stretch and all that, you're going to do more damage. So one of the standard things I tell my patients is do not stretch your hips, especially rotations. You can stretch your muscles, hamstrings, calves, do all the stretches, but do not stretch your hip into more internal rotations to come back and show me that you have better range of motion because you're going to do more damage. And secondarily, when it impinges several times, you get this cyst on the head. It's very classic. Old times people used to call it herniation cyst, and used to say that herniation cyst in the radiology literature is a benign, insignificant fibrocystic changes in the femoral head, but it always corresponds to impingement. So today we call it impingement cyst. Right? It correlates with where the bump is, where the pressure is. So it's a dislocation. You can see the cam bump. For some reason, once you dislocate and give it a few minutes, it sort of demarcates where the abnormal cartilage is a little different. Right in the beginning, it all looks the same, but within a couple of minutes of exposure to the air, the abnormal cam bump shows itself. So I don't use templates. I do look at the color. I'm kidding. I don't do open cam arthroplasty, but you clearly see, right? This is articular cartilage just became red because abnormal forces is causing, inducing. Cam bump, right there in the front, usually anterolateral. Arthroscopically, or when you do open, head neck junction extends onto the neck. The left hip, the cerebellum is here, is the femoral head. Looking arthroscopically from the top, the cartilage is extending onto the neck. So it's an epiphyseal deformity. The epiphysis grows onto the neck, extends beyond, like a bicycle helmet. I don't know, we don't use bicycle helmets in India, so what else can I use? Like an egg, instead of being a round ball, it becomes an egg shape, extends over onto the neck. Usually anterolaterally, sometimes way extends all the way back. So before and after. This is what's healthy, and this pristine looking cartilage is what's doing all the damage to the cell. Initially you may think, why am I taking out this healthy cartilage? But this is doing destruction to the cell on the other side. So you better take it out. So my patients are really young. I've operated on 11, 12-year-olds with FAI, right? So if they not have a whole lot of damage, but you always see some signs of impingement when you go in. This may look pristine to you, but there's some fibrillation of the contralateral junction, right? That's the earliest change you can expect. But I'm probing it here. There's no reason for a probe to go and touch the bone unless it's already separated, right? Same patient, I'm probing. I'm feeling subcorneal bone because the probe entered into the cleft. And look at this little carpet phenomenon, or pillow effect, or wave sign, people call it differently, or the articular cartilage. That cartilage is supposed to be firm and healthy. This is a young person. I don't know exactly what or how old this patient was, but yeah, that's often the earliest signs of impingement that I see on during arthroscopy. Little more obvious, cleft, right? Labrum is pristine, triangle, no erythema, no damage to the labrum itself, just got separated from subcorneal bone, and the probe is feeling the bone through the fissure. More advanced, if you ignore this and wait a little longer, it's not an old patient, the articular cartilage flap is coming off. When you don't peel this flap, it looks pristine. On an MRI scan, you'll miss this flap because fluid can't get into that subcorneal cleft because the head is pushing on it. So if you really want to see this cleft on MRI, you distract and inject dye, which most of us don't do. Distract on the hip, when they're awake, it's pretty hard. Is cam impingement pretty obvious? Everybody understands cam quite well? All right. Pincer impingement. Pincer impingement basically means the labrum is getting crushed between the acetabular rim and the femoral neck. Femur and the acetabular are squeezing the labrum, crushing the labrum every time. They flex and internal rotate. So when it happens, you start seeing sclerosis of the neck, you see grooves in the neck, labrum gets calcified because it's getting squeezed and squished. The calcification of labrum exacerbates the impingement because the coverage increases by a few more millimeters as the labrum becomes hard, ossified, and calcified. And the carpet phenomena is only a few millimeters from the rim because nothing is entering and squeezing the articular cartilage, just crushing of the labrum. That's a minor damage to the articular cartilage right next to it. Pincer, flexion, squeezing the labrum, gets folded, torn, and the damage is not very deep, only a few millimeters deep on the acetabular. This is what the counter-coup damage is. See, this is impinging. This one would subluxate and dislocate from the back. You won't dislocate because the capsule is pretty tight and uninjured. but I want to subluxate a little bit. That force can do counter-coup damage on the posterior aspect of the sternum. It's pretty rare. Look at the difference in the labrum. This one is getting crushed. This is a young person, haven't had disease for too long. So you may say, well, that doesn't look too bad, but compared to a triangular, nice, healthy labrum, this one is all crushed, has redness, split. Its consistency won't be good when you probe it. So that's the pincer impingement. So I make actually cam versus pincer diagnosis intraoperatively. I don't go in saying that acetabular is overcovered, crossover size, or this pincer impingement. Impingement is a phenomenon that happens inside, and I differentiate between cam and pincer intraoperatively, which is more accurate. Okay? This is the type of changes you can see at the head neck junction. From that rubbing, the femoral head cartilage is wearing down, and the redness is from that. That's a band of tissue. This actually helps me and that I need to go medial to this area to do my osteoplasty. Right? If impinging at this point, it should be at least more medial, and definitely not lateral to this. Pincer damage, acetabulum labrum is all red streaks, getting squished. Little articular cartilage damage right next to it is more advanced in the previous cases. Here, there's softening that extends further deep. So it's mixed impingement. Pure pincer and pure cam are not as common as mixed impingement. 87% of FAI in one study was mixed, both cam and pincer together, both damage and morphology. So this is showing the finished product of doing everything. It's not distracted, the hip is not distracted anymore. The head is in the socket, all the way reduced. So what I did here is, we did the neck osteoplasty. I told you that most cam is from the epiphysis growing onto the neck, so your resection has to go medial to the growth plate. This patient has to happen to have open growth plate. It's not a contraindication to do osteoplasty. So you have to go further medial than the growth plate to get into the epiphysis to get the deformity. In a skeppy, the deformity is all lateral to the physis. You never have to go medial to the physis. Make sense? This articular cartilage growing onto the neck, and you're going to resect it, and you end up going more medial to than the growth plate. And there's a labrum after. We did the rim trimming. When AIS is right up here. So did the rim trimming usually on the right hip, between 12 to 3 is where the impingement happens. So I know where 12 to 3 is after scarpages are open when you look at it, because I don't need X-ray. See how thick this thing is. This becomes very narrow at 12 and at 3. So it's like a, what's a good, they call it TP in America, like a conical thing, like a triangle. You can call it 10, yeah, sure. Right? So, very narrow at 12, very narrow at 3, in between it's pretty wide, and goes to the AIS. So my resection here was anterior rim trimming all the way to the AIS, and the labrum becomes unstable because there's so much bone behind it, so I'm going to put the labrum back with anchors to sew it. I like this picture only because it shows everything that can be done arthroscopically in FAI. Rim trimming, labrum repair. If you have to reconstruct the labrum, you can reconstruct the labrum and then do the osteoplasty. This is one post-op X-ray of osteoplasty. You can go pretty deep, but you probably don't have to be that aggressive with the depth because you want to make sure that you leave enough neck that won't break on the long term. Right? This is what I'm saying. This is femoral head-induced pincer. You can see clearly that the labrum is pinched and the rim is pinched and going up, and this is purely from femoral head deformed. The skeppy that never remodels. Don't assume that all skeppy is remodeled. The bump keeps hitting, and that labrum got destroyed there completely. Right? So femoral head-induced pincer. Again, showing occasionally you see a cyst happening in the back. I've seen it several times. It's usually a suprafoveal cyst in the femoral head. That's from counter-coup damage in the back. That I've seen. But the true counter-coup damage, like acetabulum damage here, is a patient of mine. It's the only case that I could document posterior. This is femoral head, acetabulum, this is posterior aspect, worn down cartilage from counter-coup damage, or femoral head subluxating against the labrum in the back. Okay. Posterior damage from anterior impingement. Now showing you some sketches. Mild sketches. This is raw neck bone that came through. I didn't do anything yet. I'm just looking inside. Look at the labrum. Red, right, from the irritation. The retinaculum is torn. It's a stable slip. It's not unstable. And the bone starts getting exposed to the retinacular rent. And the articular cartilage is inside. So the neck is already entering the acetabulum at the angle at which we were. Probably we were at 30-40 degrees of flexion at this time because I'm looking at the separate compartment. So that'll be in flexion. So this bone is already engaging the labrum, rubbing against the labrum. And if you flex more, it will rub against the articular cartilage inside. And this is very young, early slip, very mild slip actually. I should have shown the X-ray too for you to understand. So you understand this labrum, head inside, neck, and the distal femur right there. It's the right hip looking from the superior aspect. Are these arthroscopic pictures making sense, or is it?
Yes.
Yeah, okay. So after distraction, in the same patient, right? Look at how it's scraping that little spike of bone. It's soft, it comes through and scrapes. I agree with you that if you leave the slips alone, the neck will remodel, the bone will go away and the range of motion improves, but at the expense of rubbing against labrum and articular cartilage. And the labrum and articular cartilage is hardy and the biology is good. They may not get too much damage while the neck remodels, but if they don't have, they'll do a lot of damage before the neck remodels. Yeah. This is from Mike Mills' article in JBJS showing how the labral damage is not cam damage, right? Cam, I showed you pristine triangular labrum that just got lifted up. Look at the streaks and everything else here. So SCSI causes pincer damage of the labrum first, and then abrades the labrum and the articular cartilage, abrasion against that raw bone that causes all this damage in the SCSI.
Can you go to on the right side?
Oh, this is another patient. This is the milder one. This is a little more moderate slip, where look at the labrum is completely crushed and everything is getting worn out. The bone is just digging into the articular cartilage. Right? That's what you're relying on for your remodeling, for the milder slip. I'm not going to tell you that all of them will get arthritis, but damage is happening.
So you routinely scope all your...
I do not routinely scope. I'll go through my SCSI classification and tell you what I do in the next section. All right, again, comparing the two.
Would you say that SCSI is a combination of CAM and pincer?
Well, if you look at it purely for the shape of the head, it's CAM, but pathogenesis-wise, damage-wise, it doesn't do anything like CAM. The next two slides will make it clear for you, at least my idea. This is idiopathic CAM, from epiphysis growing out of the neck. The bump that caused the damage is this nice pristine articular cartilage, while the damage here is raw bone, right? That's number one. Then in SCSI, this cartilage looks very good, just soft, right? And the flap develops afterwards. If you let the flap go back, this cartilage is never rubbed. The superficial layers of the cartilage look pretty clean, neat. Here, the cartilage is getting abraded. There's no full thickness flap in the establishment. It's just abrasion of the establishment. Right? And look at the X-ray again. In an idiopathic CAM, the epiphysis extends. So you know that it's all covered with articular cartilage. The scar is going way over here. This is how far the epiphysis has grown onto the neck, causing this bump. The bump here is purely bone, neck bone coming up anteriorly and crushing all the pieces are because trying to get remodeled, but in the process of remodeling, it's rubbing against the labrum and the articular cartilage. So if you resect, if you're doing surgery open or arthroscopic, you better go well medial to the physis to get the cam shape gone, like get the sphericity back. Here, you don't need to go even this far. I just did this to demonstrate to you that this is the growth, to show the growth plate. You never need to go medial to the growth plate in a SCSI. Right? A simple angle, put it inside the screw, start with the articular cartilage end, and deepen the neck, take the bump off. It will prevent probably the damage in milder slip. So in summary, SCSI has posterior tilt. Idiopathic CAM has anterior tilt, right? It's anterior tilt, anterior overgrowth. So they're not the same. Some people say idiopathic CAM is probably a residual undiagnosed slip, a mild silent slip. It's not. 90% of the time, 99% of the time, it's not. Posterior tilt in SCSI is anterior extent of the physis, anterior tilt, if you draw the line. Bump is from the neck bone in SCSI, it's epiphyseal cartilage on CAM deformity. Pincer and abrasion is the type of damage that happens in the SCSI. When you look at it arthroscopically, Hartford phenomena is how things happen in idiopathic CAM. And then osteoplasty to the physis and medial to physis in CAM. That's a summary slide of things between the two. Trying to figure out what I'm trying to show here myself. Well, this is a series of what causes CAM bump, right? Some people say, I'll show you the series of it, but here, this particular patient developed CAM because the trochanter and the head did not separate. The growth plate It's a common growth rate in the beginning. It separates in probably first year of life, second year of life, and then they grow separately. Here, it's not growing and tilted the head into valgus, and there's a tether on the lateral side. So that may be an etiology, a delayed separation between the two. Maybe the cause of CAM is a theory out there. I don't believe in it, but I will tell you that that's there. Yeah, all right. I'll go back to etiology in a bit, later slide. Now, how do they present to you? Hip, groin, thigh, or knee pain is what is typically present, right? Pain is sitting in flexion. People say it's typically from impingement, but it's just as frequent for me for patients to come and say, I get pain when I run. I have no problem sitting, but I have trouble when I run. After I run for half a mile, my hip and knee or whatever gets sore, right? So pain doesn't have to be from flexion only for anterior FAI. Probably the damage happens in flexion, and the irritability causes them difficulty running. That's my theory as to why it happens. All right? They may computer clicking from flaps that develop, chronic stiffness. The stiffness is not like they don't have range of motion in other directions. They can't sit deep. So I never was able to squat from the. Both my sons were never able to squat down, and I couldn't figure out in the beginning. Right? They didn't have enough range of motion. Now, I mentioned a little bit about this before, with the avulsion fracture. In addition, sports hernia, I don't know how many of you know about sports hernia. It's not really a hernia, but a tear of the abdominal muscle, rectus, attached to the pubic symphysis. People call it sports hernia, and you need to do some hernia type repair by general surgery. Osteoid pubis, you get the pubic changes on X-ray and pubic pain. Muscle strains around the hip, avulsion fracture, like I mentioned, SI joint pain, right? Not all, but some of the SI joint pain, and some lumbar pain, lumbar strain, may be secondary to the hips being stiff. You may be compensating with the abnormal motion in that area, abnormal stress in those joints, because the hip is stiff. It's like if you fuse the hip, you're going to get back arthritis and knee arthritis. This is not fusion, but you're not able to go in that direction, so maybe you're stressing all these things. So these can be associated. There's no way to prove the association, but they happen at a high intensity. Whenever you see this and you examine them, and if they're FAI, I tell them that I'm going to get an MRI to make sure you don't have any back issues, but I'm going to treat your FAI and hopefully these will go away. At least that's what I tell them, and that's what I've been doing. Now, more importantly, traumatic hip dislocation. I can't remember anyone with a traumatic hip dislocation that did not have CAM morphology. Because it's established fractures, pelvic fractures, they're big CAM morphology. I'm not saying that they impinge all the time. So we did actually studies on population-based things, trauma patients with dislocation, we found a very high incidence of CAM, like deformity, based on APA angle, right? So the case reports of recurrent traumatic dislocation, where somebody didn't have enough range of motion in the front, the posterior capsule got ripped, the first time they got trauma, never healed enough, and every time they flex, they can dislocate, and this can lead to recurrent posterior traumatic dislocation. And you shave the bump off in the front, and they stop dislocating. Right? There's one case I know of a femoral neck non-union from repeated impingement, and when they shave the bump off from the front, the neck non-union heals. It's a case report. They can't make a whole lot about it, but keep in mind that the stress from the impingement may be putting too much stress for that bone to heal. Signs, now exam. We talked about symptoms, now the signs of, I rely on clinical exam a lot. That's the basis of my diagnosis, right? Flexion, adduction, internal rotation, people call it saddle, or the impingement sign. You flex up, you adduct, and you internal rotate to squeeze the anterior labrum between the neck or the head bump and the sternum, right? That's called impingement sign. If you get that, that's pretty accurate about not for impingement, for hip disease. It localizes the problem with the hip. Hernias, muscle strains usually don't cause the pain. If you get pain when the bones are touching and you get pain, that's from the labrum or the articular cartilage. It's sensitive, but not specific. Every hip pathology will have the cause. Every hip condition will hurt with flexion internal rotation. Flexion internal rotation range is what I really rely on. When I do that exam and they're painful, I carefully look at how much rotation they have. And this is very subjective. Even in my own notes, I may say 10 degrees last time, and this time I'll say 0 degrees. A lot of things affect it. It's not as objective as you're saying. Even if you goniometer, it's not going to be very accurate. You need to make sure that the pelvis is level, the bed is not too soft and saggy, they're not tilting one way or the other. And subtly feel when the pelvic rocks and measure that measurement. So, though I rely on it a lot, it's not very reproducible for everybody. So you need to develop your own strategy to measure the internal rotation. Flexion, abduction, external rotation, I mentioned this already, favored. That causes pain in lateral impingement. We talked about that. Straight flexion pain in subspine impingement, we talked about that also. Subspine AAIS, straight flexion pain, and posterior stress for the posterior impingement. These are all different signs we have. So this is one of my patients. I don't remember exactly what started. It's a beanbag. So I'm probably doing a surgical dislocation on this patient, but so fine. I'm just trying to demonstrate what they had. Right? Oh, I think it's the video supposed to play. Sorry, hold on. Right, straight flexion. Look at that. Right, 0 degrees of internal rotation. But you can make it look like 30 by yanking and letting the pelvis still. So don't let that happen. Make sure the pelvis is not rocking and you move it. Again, showing it in a different angle. 1990. It is anesthetized already. Showing you that 0 degrees of internal rotation with a bony block, right? You feel firm endpoint to it. And if the patient is awake and complains of pain, the diagnosis is made. Nothing else hurt. Flexion internal rotation restricted. Pain with that motion limited, right? That's impingement without any question. There can be other problems, but at least you diagnose impingement there. Showing on the opposite side. Right? Obligate external rotation deformed here, 25-30 degrees. Right? This is pre-op before a done osteotomy for me. Just demonstrating that. So let it go into obligate as much rotation needs to, then bring it and feel the pelvis rock, and that's how much deformity patient has. For me, it's a very important test to figure out what they have. Yes?
All these tests are designed to checking flexibility
for anterior impingement.
for anterior.
Because 90% of impingement I see is anterior. So I'm showing you how range of motion can vary between your and my exam, and I'm recommending that you do it like I show you. Don't let the pelvis rock. Feel the subtle block, and when it blocks, you start measuring your range of motion.
Then why running? It is getting up from sitting position will cause similar symptoms. While running.
Why will it hurt? So once you have labral damage and caudal flap developing, I think the grinding will hurt anybody.
That's an advanced stage of.
That's what I think. I don't know where to prove it. Why would anterior FAI cause running pain? That's how I came up with. And my patient gets better by taking the bump off. It's very good. It's like, no, I don't want to comment on Jan. He said all his shelves work, so all my scopes work also is what I want to say, but.
Indiscriminate.
All right. So for workup, we already talked about AP pelvis. Get some type of lateral view, right? A frog lateral is easy to reproducible to get, but it may miss the cam because you're going to look way down below where the cam is with the frog lateral, right? A shoot through lateral is pretty good. It shows you anterosuperior aspect of the head and neck junction. A done at 45 degrees is probably ideal to show the anterolateral bump, right? But these are not easily reproducible. There's too much radiation to shoot through. You can go only one hip at a time. So I prefer just a frog and interpret what I see on AP and frog as to what in between the two. Try to figure it out. MRI non-contrast. I did my first 83 hips I've operated on. I did MRIs in everybody. I said, I'm not going to operate without an MRI. But I found that I picked AVN in one adult I didn't suspect. But when I talked to him, he's an alcoholic and he's been having chronic pain, night pain, rest pain. I could have picked it up easily. And one person had an EG in the pubic ramus. Still had impingement, but I had a eosinophilic granuloma that I found. So I stopped doing MRIs after that because they don't change what I do for these patients. If you want to see a labral tear, and plain MRI is not adequate. Only 20% of labral tears are seen on plain MRI scan with the older technique. With the 3T and higher, you may be able to pick up more. I'm not aware of any studies. If you want to see labral tear, get an MR arthrogram. But I don't do that just because labral tear, in my opinion, is just a finding or a earliest thing that will happen. Does not tell you the diagnosis, does not tell you what to do. And I'm going to see it anyway when I open it up or do arthroscopy. So that's why I don't rely on MR arthrogram to look for a labral tear. I use this quite often. If you have any question of the etiology of the pain, somebody says they have pain only when they run and only in the knee, and I examine them and I can't show any pain at all, then I say, I don't know where it's coming from, I'm going to inject your hip and you go run and see what happens. 90% accurate. There are false positives, false negatives every test, but the closest I can get to perfection is with this, 90% with this test. Local anesthetic, without any anesthesia, without any sedation or anything else. So again, we talked about all these things. I don't need to repeat. We're going to look at all this social angle, social shape, right? Okay. I'll go through this quickly. You saw these. Nobody has any questions about these walls and path and all that. Crossover sign, we talked about it. We talked about this also.
If you have positive clinical signs, but X-rays are bottleneck, what makes it?
So the question is, the patient has pain, number one. The patient has decreased range of motion. So X-rays are to tell you that it's not too late to operate, and where do you have bone start to work on? Is there a cam to remove? Is there a stapler rim that I can remove? If I can't do any of those, then the most likely cause is a retroverted femur. Either you can get a CT scan to document that, or do clinical exams to figure out the version. And there, I may start with arthroscopy, but I'm very prepared to do a derotational osteotomy femur at the end if I can't get enough range of motion from arthroscopy. I don't get the version study routinely because usually 95% of the time my arthroscopy gives me good results. So the failed ones, I probably had one patient with bilateral that I had to do an osteotomy myself, and my own family members had to have a derotational osteotomy 8 years after arthroscopy. That's rare, so there's no point in getting a CT scan routinely to look for version of the femur.
How soon after they get symptomatic do you recommend doing an arthroscopy?
I believe that it's a bony problem. They have pain and I've made the diagnosis, so there is no time period for me. Whenever they are mentally prepared. The longer the wait, the more damage they're going to accumulate. But I'm forced to wait with certain patients in America because the insurance says that you haven't sent them for 3 months of physical therapy, you haven't got an MRI, you haven't done non-operative measures. So there, I'm forced to wait. Or if the patient is not convinced that they need it, I say, go back, do your things, you come back if you want to. And majority come back. We sort of cross our sign, I'm going to skip all these, sorry.
Prasad, what do you think is the incidence-wise slightly higher in the Western countries? I mean,
I'll get to the etiology. I think I have some theories, at least some evidence and some opinion. All right, pay attention to this. Look at this growth plate, it goes way over. You may say, well, the alpha angle doesn't look too bad. AP view, if you are drawn an alpha angle, the sphericity probably goes down to here, to the center, so probably 50 degrees, no cam. You may get a lateral view on the patient, and it looks at it right here for a prololateral. There may not be any cam on that, but right in between, this epiphyseal line growing out of the neck will tell you that there is cam. And intraoperatively, I can see it because I'm going to do it at different angles and keep shaving the head neck junction, and there'll be a cam right here. So this is an indirect sign that there's cam morphology. Right? It's epiphyseal extension sign. You can see it on this side also, right there. Let's talk about this. I should have took some of these off. All right. Mild scapy, right? Very mild scapy, but has limitation of range of motion, deformity. So this slide probably has my philosophy, or whatever I want to say to you, summarized here. Morphological abnormalities are very common. I think in this hack study, American football players 18 to 19 years of age, before they go into the NFL, they have a combine and they all get X-rays. 90% have prominent cam morphology with alpha angles more than 60. Doesn't mean that 90% are impinging. They have cam morphology. Now, some of them will impinge at a certain point, and if you examine them, they probably have pain the way I examine them, and they may be candidates to have something done. But this is just not knowing about the symptoms. 90% have, 70% of soccer players, children, have cam morphology. 70% of tennis players have cam morphology. So the morphology is very common. Crossover sign is very common. I showed you that my X-ray of the pelvis has a crossover sign. The kid has no problems in his hip. So very common to have asymptomatic morphological abnormalities, right? Even the slip angle, right? The simplest thing, you know how to measure slip angle. it varies with how you take the X-ray, what lateral you had. No one view will show the same, no one view will show the maximum slip in every patient. It's a three-dimensional deformity in varus and posterior slip, and it can be more varus, less varus. So the same standard, Carpal wrote a paper saying that his Billings lateral shows the slip the best. I don't believe it, right? Depending on how intraoperatively when I manipulate the C-arm, I get the best angle of the slip. So anything I did pre-op, it varies. So you can't even measure slip angle. How can you measure all those other things as accurately? And the slip angle also does not correlate with clinical deformity. There's some people with 30-degree slips that have no problems at all with rotation, don't impinge at all. And there's some with 10-15 degrees of slip angle are impinging. So it doesn't correlate. The slip angle does not correlate with variable and does not correlate with impingement. AP and lateral X-rays may show perfect head. The cam bump may be in the middle. I mentioned that a couple of times already. Some of the version influences all the others. Say I have this big cam in the front, 65-70 degrees of alpha angle, but my femur is antiverted 35-40 degrees. That's going to compensate fully for the cam bump probably will never engage the sternum to have any damage. And our studies don't take into effect. People are thinking about this and they're saying, we'll come up with a combination of all these things put together as an index to say, if you have this number, an index of 15 with version and all these things, it's impingement. What I submit to you all is, don't worry about that index. You have range of motion exam that will give you a summation of all the morphological problems. Take the cell, everything into consideration to do a careful clinical examination. The only way the time you fail with clinical examination is somebody has pseudo-laxity and you're forcing it and you subluxate there, you get false measurement. But I'm not going to do this. I told you, mild, gentle motion. You don't cause subluxation, you don't force anything, no pelvic tilt, right? So none of these parameters, right? None of these are diagnostic of FAI. Alpha angle of 70 doesn't mean that they're impinging. They may be asymptomatic completely and may not have any problem. Crossover sign, retroversion protrusio. They don't mean that they're impinging or having problems. First of all, they have to have pain. Second is you have to show an exam that hip is the cause and you have restricted motion or whatever, different problems. So with my experience, it's a long time ago, 2007, 2009, where I put some cases together and was able to come up with don't worry about the four types, it's two clinical types of FAI. Essentially, anterior FAI, there's two types. One, a clearly restricted range of motion. Very obvious, you flex them up to 90. Normal, I believe, is 20 to 30 degrees will be normal. You need 20 degrees to have healthy hips in a regular person like you and me. Some people who do a lot of twisting and all that, they need 30 or 40, right? Depending on their activity. But most normal people need about 20 degrees of mental rotation. If you're very fat, you don't need 10 because you never get to that point where you're going to impinge. So it depends on the person. So you have clear bony block, less than 20 degrees. It stops very clearly with a pain reproducible in the groin, right? Reproducible pain, restricted range of motion. That's a classic type 1 FAI. Just by examining them and you get the feel for the range of motion, even before you get any X-rays, they're candidates to have something done. Their hip is in trouble, they can be helped with intervention. Then you look at X-rays to see what you can do to make them better. Clinical exam first, diagnose it. So this is a classic, very obvious FAI, type 1. Right? Now I put a subtype here only to show that those patients who have pain running, they have limited motion when I examine them, but I cannot reproduce their pain. I sort of know that it's their hip, but I can't prove it to myself or them yet, put them through an operation. So these, the next step, they get an intraocular injection for diagnostic injection. You confirm that it's the hip, and then take care of the range of motion based on what you see in X-ray, plain X-ray. Improve the range of motion. So for type 1, the goal is to improve the range of motion. So you have to see where you have bone stock to work on. You always improve range of motion by doing acetabular trimming. Every millimeter of acetabular rim you take, you get 2 to 3 degrees of rotation improvement. Automatically, no question. You can't be as reliable on cam. With a cam, I may have a 70-degree alpha angle and say I'm going to bring it down to 40, and I should get 30-degree improved range of motion. It does not work that way. Because the cam may be already be contained in the hip. The range of motion is already taken care in the range of motion measurement, so it will not improve sometimes. Right? The second type, so ignore type 4. Type 4 doesn't exist anymore. That was when I was stupid, I couldn't figure things out. I put a type 4 there saying that I can't diagnose. 3, 4, you can lump them together as they have great range of motion in exam. They have the 20 degrees you need easily, but that range is painful. That range causes hip pain, knee pain, whatever pain it causes. They have good motion, but they have pain, right? These are almost always from cam. A small cam that's entering the hip, right? Sandeep, is there any concern? Give me a minute. Yeah.
Are we going to do arthroscopy with the stethoscope? Sure. So, what we have, I don't need the hospital charge, but they have a good side.
All right, shall we continue? So is this clinical classification pretty clear? Restricted range of motion with pain, reproducible, it's pretty obvious. It's not reproducible pain, inject and diagnose that it's coming from the hip. They have restricted range of motion and there's hip pain. So these patients are at risk for having more and more problems. They need treatment. Go to look at an X-ray to see what you need to do to make it better. MRI, CT scan won't change what you do. If you're not sure where this bone stock is, yeah, get a CT scan, whatever helps you. You need to do it safely. Until you understand looking at X-rays carefully, you can get a CT scan whenever you want. You say, well, I don't know how to look for cam, I want to see how much cam there is, I'm going to get a CT scan. This radiation is cost, but it's safer than doing the wrong operation. The second type is they have a great range of motion, but they're having pain. This is when the cam is entering the sternum and doing damage to it, and there's no bony block that can appreciate clinically. Right? These, you have to get an MRI to make sure that there's nothing else going wrong. It's like medial meniscal tear. I would not operate on the knee, an arthroscopy of the knee, without an MRI, look at the medial meniscus, because my clinical examination is never accurate. Medial joint space tenderness, I feel, is not good enough for me. So I want to get an MRI, 90% accurate. But labral tear is not important, and it's not accurate. So I skip MRI in type 1, I don't need to. But type 2, I have to make sure that there's nothing else going on before I focus on the little cam bump that may or may not be causing him pain. Okay? So you get the MRI, if you need, you can do an injection, and then all you have to do in this case, regardless of what the crossover side looks like, is just take care of the cam. Just make it rounder. Just shave it. So my type 1 anti-FAI, 2/3 of my patients were very clear-cut FAI, anti-FAI on clinical examination, right? And 92% of cases at that time all had anterior impingement. So 8% did not have impingement, that's great motion. So some slips don't have restricted motion or impingement, right? A small percentage. So in these patients, you can do all the physical therapy you want, it will only aggravate the pain. If you want to make sure the pain comes back to you, send them to physical therapy saying range of motion exercise. Physical therapist will yank on them and the patient will come back to you saying that I'm worse with physical therapy, please fix me. Right? And the role is to do surgery to relieve impingement and increase range of motion. You have to get them back to the 20-30 degrees range of motion based on available bone stock. We have it in the neck, we have it in the rim. Right? That's when the wall coverage and all come into play. The 20%, we have 20%, we have 30%, how much can it remove? Case example, you see this cam bump on the AP view, right? So this is a big cam. I don't even need a lateral to look at the cam in this patient because that's a reasonable cam with growth rate overgrowth. Look at the sternum. No neck in the front, look at the neck in the back, right? It's actually digging in there. So you may say, well, it's cam impingement, but why would you dig with cam impingement? That's a combination of tensor and cam. That's the rim of the sternum digging into the neck, causing this little groove. So I showed you this ball already. It may not be the same. I have mixed and matched the pictures, so don't say, I'm not trying to be dishonest here, I just want to put across the point that this may not be the same patient. Right? So cam, you take care of that, you improve the range of motion. X-ray wise again, this is the same patient as saying, you create a concavity. And you have to use fluoro, because you don't have any templates to use in properly. So you have to use fluoro. Both bilateral impingement, this was not operated on, this was operated on afterwards. So we create an offset to improve the range of motion. Cases, clinically impinging, the rim was doing damage, put a screw. You see my screw technique is a little different. I put it posteriorly along the posterior neck so that I have room to shave the neck of the scapula at the same time. Type 2 FAI, I told you about 11%. I injected them for the diagnosis. The treatment is the same. The patient has crossover sign, right? But not that much posterior dysplasia. So I think in this case I felt comfortable and did some rim trimming. In the front. So in the lateral view, see the subtle cam bump? Doesn't look very spherical, but compared to the back to the front, there's no neck coming down there. So this patient had a little work on the rim, it's not as prominent here. Little rim trim and neck osteoplasty. FAI3, I told you about 18%. They had good range of motion and still had pain. Usually it's not usually, it's almost always from a small cam bump or cam morphology. They may have mild dysplasia also. Then here's where, you want to get an MRI to see the labrum is hypertrophied. If they're hypertrophied, you don't want to do arthroscopy and make it unstable. But the labrum is nice. You do careful arthroscopy, maybe capsular repair. This is one time I do a capsular repair to decrease the risk of instability in the hip and protect them in abduction. Take more precautions because it's dysplastic to start with. I don't want to have any dislocation issues. So you get an MRI to make sure that there's no labral hypertrophy. Usually the range of motion that I get intraoperatively is less in this patient. So I start feeling like they're restricted also. Just that when they're awake, they're allowing the cam to go in. And you do cam, I find cam damage intraoperatively, discal cam, and do cam osteoplasty only. Another example here, subtle cam, not a big cam. I got an MRI, no labral hypertrophy, but you see the facial extension signs that support cam development, and already does osteoplasty. A little deeper than expected. I could have, to perfect osteoplasty should be leave a little more bone and come to keep the sphericity. But you saw Reinhold Ganz's osteoplasty where he actually took out so much neck, so I don't think it's a big deal if I did more. But if you take too much here, you can risk neck fractures. We'll skip FAA4 because it doesn't exist anymore even in my own practice. This is a sketchy patient. I'm going to skip this. Okay. What happened here? Something happened. Yes. Pardon? My talk is not done yet.
Question that you say that a lot of these patients have a cam, but they are symptomatic. Like there's so many patients just as a routine they did examination and they found that they had a cam or they had a scapular impingement, but they were asymptomatic. How do you blame that cam? Ultimately, after the cam has been removed or the fissure has been removed, do they number one question is, are all of these very highly active in some sporting activity or something?
Usually most of the children in America are active. Most are.
After doing this, do they go back to their same sporting activity?
More than 90%. I didn't do a formal study, just by looking at my experience, because hip arthroscopy is the most common operation I do. So I see a lot of patients. I put at about 10% where they have some residual problem. 90% do really well.
Of the 90% who go back, how many come back within 1 year, say 2 years? No,
very, very rare. The usual coming back, people who come back to me are people I didn't take enough bone. Right? My osteoplasty was not perfect. I'm afraid that I'm going to take too much, so I don't go as medial as I should. Intraoperatively, fluoroscopy is not the same as postoperative X-ray. So postoperative X-ray shows residual cam, but intraoperatively, I thought I was perfectly in the sphere. So I make that mistake. Used to be about 10% till a couple of years ago. That's come down because I'm being more aggressive and going more medial. So about 5% have to redo their surgery.
The patients will say that when he runs, he gets the pain, and otherwise he doesn't have pain. Walking and standing, he's not having pain. Does he have hyperlaxity?
Hyperlaxity doesn't really play into my decision making at all. So even if they're lax, I can't believe that they'll have pain from running is not from hyperlaxity in my opinion. It's a instability pattern from some golf swings and things like that people have reported. I haven't had any patients that are treated for hyperlaxity.
Couple of patients have pre-existing stiffness. Stiffness means they cannot squat. So with this, medial open surgery, the pain went away, but still they could not squat.
Well,
what do you do?
So what happens is when I do my sketchy osteotomy, they get 40 to 50 degrees of range of motion after the osteotomy. But if the trochanter back and the muscle gets stiff, they come down to 10-20 degrees. So I'm not too worried about it because they're not impinging on the hip anymore. It's outside stiffness. So if you did an adequate job and the pain is gone, I think it's okay. All right, so the study summary, type 3, type 4 also primary. Here are my results on the 2009 series, right? I was able to get good FIR, good range of motion, 82%, and pain relief at 94%. And I had 2 patients that had significant pain after 6 months. So that answers your question about what percentage people have trouble. In that series, at 7% iatrogenic damage, arthroscopy has a steep learning curve, and even today, I can't guarantee that I can do a scope without some minor damage to something. The incidence is lower and lower, but some level you take, the needles go in sort of blind, not blindly, but on the fluoro. You don't exactly know where your initial needle is going. So it may go to the labrum, hit the cartilage. I have some techniques to do it better, but I still can't guarantee that there won't be any damage in a particular case. So there is some minor iatrogenic damage of not no significant consequence, 7%. When you put traction on them, about 5% have pudendal palsy. They can't feel the private area. That's a pretty bad, devastating thing for a male, but usually it's temporary and will come back. All right. So limitation of this approach, that I'm going to tell you myself, clinical assessment subjective in my own hands, 10 degrees, 5 degrees, 15 degrees, it varies in my notes. Last time I may say 15 and this time I'll say 5. But still, the overall judgment-wise, I still has the grouping does not change. Treatment is individualized, so you can't make a big deal about the series. And I didn't use any outcome tools. I just said who came back with pain. Well, we talked about crossover sign. I think did we see all these? Yeah, we saw all these exercises. I'm going to skip through them really fast. Did I show this protrusio case? I did, right? Do you remember this case? Very overcovered, AAI pretty prominent. In the planning from here, I need to take it down to here. I think I showed this. And that's what it reflected right there, arthroscopically.
Yeah, you put it on WhatsApp.
Okay. I'm getting confused here. All right. So a lot of things you can do arthroscopically also, even for major deformities. What am I showing here? Oh. I showed this already for the PAO, ideal PAO technique, so that's fine. Did I show this? Yeah, I did. Right retroversion PAO, I showed this. So my current approach, anterior FAI is a clinical diagnosis. Once you understand this and train yourself, you can diagnose FAI pretty reliably on just examination. Because none of the radiographic investigations are diagnostic of FAI unless you wait till they're 25, 30 years old and have this cyst, the labral damage and alpha angle changes and secondary changes on the head. You wait that long, you may be able to find diagnostic things on x-rays and all, but it's clinical diagnosis. Pick them early. Treatment is based on radiograph, not an MRI or CT scan. Plain x-ray shows enough details to work on. And labral tear is not a diagnosis. Don't operate on somebody for a labral tear. Try to find out what caused the labral tear. And in addition to repairing the labrum, fix the underlying cause. Right? It's not just my opinion. There are studies to show that labral debridement and labral repair with no bony work continued to have arthritis and went on to total hip replacement. It's a Glick study from 15 years ago. Right? So you have to take care of the cause of the labral tear every time. All right. So any other questions on this introduction to FAI?